Suicide, especially amongst the youth, has been an ongoing public health concern for us here in Zambia. We are trying to see how we can improve the detection of suicide presentations to see how we can best care for these individuals and reduce the prevalence.
There was a huge problem with underreporting because there was a big inconsistency between what the professionals, the health clinicians were saying. They were seeing a lot of suicide attempts being reported, but the reality was that in the data files, almost nothing was there.
The key, I think, is creating tools which are contextualized to our setting that will be sustainable and building capacity within our health system. Of course, yes, we have seen an increased trend in the reporting of suicide presentations, but data guides policy. So we believe this will help in that regard.
Welcome to Mind the Gap, a podcast about what's missing in global mental health.
I'm Christy Savetta.
I'm Chris Underhill.
And we're here to explore the stories, solutions, and systems shaping mental health around the world.
From community champions to global change makers.
Let's dive into what's working and what's not.
And what it'll take to close the gap.
Welcome back to Mind the Gap. We are joined today by Dr. Francisca Bwalya and National Mental Health Coordinator at Zambia's Ministry of Health. She's a consultant psychiatrist and a national leader in mental health policy, training, and service delivery, driving forward efforts to expand access and reduce stigma across the country.
And alongside her, we're thrilled to welcome Dr. Irene Falgas-Bague, a psychiatrist and global mental health researcher based at the Swiss Tropical and Public Health Institute and Harvard Medical School. Her work focuses on co-developing and implementing culturally relevant, evidence-based mental health interventions. Francisca, Irene, welcome. Thank you for joining us.
Thank you. It's a pleasure having us.
Thank you so much.
We are really glad you both can join us, and we're really excited to dive into your work. Francisca, could you start by explaining why the Zambian government made suicide prevention a priority?
So suicide, especially amongst the youth, has been an ongoing public health concern for us here in Zambia. We've seen an increased reporting of suicide presentations, and unfortunately, some of them completed suicides. So, of course, that has gotten our attention, and we're trying to see how we can improve the detection of suicide presentations to see how we can best care for these individuals and reduce the prevalence of suicide presentations. Then another key aspect is that we've had a challenge with data to really ascertain the gravity of these suicide presentations. So we're happy and glad to meet Dr. Irene and team so that we could see how to improve that area, to improve the surveillance around suicide presentation in the country. Thank you.
And what does that strategy look like in action, Francisca?
Of course, we started with policy. Policy is the key aspect. It's the beginning to guide this process, and we prioritize that. And we are also we've worked around some tools that are facilitating the collection of data for these suicide presentations, creating systems on how to improve that collection of data. And I don't know about you in the Western world, but with the limited resources and in our context, there are a number of challenges that could cause a lack of collection of data around suicide presentation, including cultural, traditional aspects or myths around suicide. So we have focused initially in the health sector, in the clinical area, to see how to improve data collection, and not only of completed suicide, but even presentations of suicide ideation, parasuicide, to be able to track these presentations and see how we can support individuals presenting with those. The key, I think, is creating tools which are contextualized to our setting, that will be sustainable, and building capacity within our health system to be able to identify these presentations as well as record these presentations, because we need that data to guide policy. Of course, yes, we have seen an increased trend in the reporting of suicide presentations, but data guides policy. So we believe this will help in that regard.
Absolutely. Makes a ton of sense. And Irene, as the technical lead with all of this context in mind, how did your team, structure and co-structure the program's rollout?
Yes, thank you, Christy. So this is a program that is completely co-developed and implemented together with the government officials and the clinical teams in each health facilities. We first started in Lusaka, so in the capital of the city, as a pilot, as a way to start and then see how we can move from there to the rest of the country. And the rollout has been progressive, following the needs of the community. So first, as Dr. Bwalya was saying, we focused on data and looking at what was the data being recorded, how many suicide attempts were already in the system, and seeing actually that there was a huge problem with underreporting, because there was a big inconsistency between what the professionals, the health clinicians were saying. They were seeing in the ER, in the community, a lot of suicide attempts, a lot of suicide ideation being reported and being in the community. But the reality was that in the data files, almost nothing was there. But not almost nothing. I cannot say nothing, but it was very, very little. And we are creating some evidence on this underreporting, as we will talk later. The first thing is that we established a surveillance system, and then we moved to understanding the current system and how cases with suicide attempts are being provided, by the care to people with suicide attempts are being cared for, and identifying the needs of the health system and the professionals to provide a better care and a high quality of care. So then we created this suicide care management training program for capacity building within the health system. As Dr. Bwalya was saying, we have focused first in the clinical setting. So we created this training program, and then we moved on to co-creating together with the health professionals and the authorities the new materials to help and guide this data collection, this capacity building, sustainability, the care management improvement. So we created key materials that I'm happy to also explain a little bit more in detail.
Thank you very much. I think, Irene, one of the standout tools has been the Zambia Safety Plan, as it's called. Could you tell us a bit more about that?
Absolutely. The Zambia Safety Plan is a tailored pre-discharge intervention that patients and providers collaboratively create before being discharged and after they have come to the health facility for a suicide ideation or a suicide attempt. It is completed collaboratively between the provider and the patient, and includes localized coping strategies and support structures that the patient can use in case they have suicidal thoughts again. So the main goal is to prevent relapse and to prevent new suicide attempts. And we know by international evidence that this is one of the best practice tools that we have, that the most evidence have to prevent suicide reattempts. This is a very local tool based on international evidence, and unlike many global templates, because it's a local tool, is rooted in Zambian realities. And that was something that we find that it's completely crucial for uptake and sustainability.
Can you share with us the importance of kind of contextualizing some of these global tools? And what are some of the limitations if someone, for instance, just applies it without that kind of local contextualization?
Let me do a little step backwards and tell you that most of the diagnostic and treatment tools that we have in mental health are being developed and validated and tested in the Western world with a very homogenic population. And I'm talking broadly, as you can imagine, there are always exceptions, but broadly, most of the tools we have, and the only tools we have, which is very unfortunate, have been developed for very specific Western populations. That means the important particularity about mental health that we know that it's so influenced by cultural and social input, like how we express how we feel and how we express distress, how we express psychiatric symptoms. It's extremely biased and influenced by our culture background and our social context. So if you have these two ingredients, the validation mostly coming from Western context, plus the huge variation of mental health expression through the context, you have that the reality is that we have tools that we actually don't know if they work in different settings. And I think this is a reality that very few people talk, but everyone knows when you work in a non-Western world, because when you don't have the appropriate tool, you just go with what you have. But we wanted to do something that actually had clear meaning and relevance and sustainability in the setting. So we really had to spend some time to co-create with the people working in the health facilities in Zambia, in Lusaka, to really accommodate and adapt the tool that it's internationally validated to the Zambian setting. Just to put you a very brief example before I stop is that many of these templates assume people will have health resources around, practically 24 hours available, and they always, are supported by who is your own health provider, like someone that is kind of assigned to you. And this is not often the case in lower income settings, where having your own mental health provider, it's something very scarce. And as I said, I leave Dr. Bwalya continue or finish with my comment.
Yeah, indeed, Irene. I think adaptation, contextualizing, I think is a major theme that's coming up. I think especially in the practice of mental health, though in health generally as well, but mental health specifically, because when we talk about our mental well-being, which involves how we think, how we make our decisions, our social life, we'll agree that our core values, our core beliefs, which are largely affected by our environment, our culture, our traditions, comes into play. So there's a lot of room to actually adapt global international tools, which are good, which are great, and they can be a backbone to work with or to work on, but there's still a great need to adapt to various settings. And low and middle income settings, I think, have special needs, have special lacks that sometimes these well-developed tools or systems or structures may not fit in perfectly in those settings. Hence the need to get these lovely tools that have been created after so much research and see how we can make it work in our settings. So I second the point she was trying to put across. And even through this process, I believe, Dr. Irene, it was a learning journey for you as well with your research team, listening from our clinical care specialists on the ground on what the picture you were giving and how we could actually create something similar within our settings, different systems, different numbers or quantity of mental health specialists or just health human resource to attend to, infrastructure. So there's a lot that comes in, and I think it's important that such studies should be specific. If it's meant to facilitate or improve care in low and middle income countries, they need to come and be tested, adapted, and validated within our settings, and including or involving the local people in that system or setup.
Maybe something that would support these is a very, very practical example on the safety plan. The safety plan is done to be done before discharge. And many people, when they are in the ER in Lusaka or in other facilities in Zambia, they will be discharged by the internal medicine department, and they don't have this capacity on thinking about what are the unhelpful thoughts or the risk thoughts that come to your mind when you start thinking about ending your life. And they don't have the capacity to refer immediately to the mental health provider, because most of the times it's either in the afternoon or at night or on the weekend or on days that the mental health team is not there. So how can we ensure that we actually implement the safety plan, and at the same time we accommodate to the reality of this scarcity and these limited hours of mental health providers that the health facilities have? So trying to adapt that was one of the examples, and we found solutions, and they are part of one of the tools, the clinical guidelines that we created, but it's just an example on what are the obstacles that you have to actually discuss with the local team.
Yeah, thank you for that. I mean, it's an incredible practical example as well in terms of what you did have to discuss and really grounding it into reality. And mental health is one of those unique fields, right? I think Irene, you said, this like mental health variations. It's not binary, and it's incredibly cool. Incredibly cultural and incredibly contextual. Even within one country, there are multiple different areas and ways of how we talk about and think about mental health. One of the things that's coming up to me here is, it makes it really difficult to measure progress, right? And so, I'm curious, and I know, Francisca, you mentioned it earlier a little bit around like the data scarcity issue and how difficult it is to not just measure progress, but also measure what's actually happening, because folks have different interpretations of what it means. How do you really measure that? So I'm curious a little bit, within the project and what you guys have been doing, what's being done to address the issue, I suppose, of data scarcity around suicide?
Yes, indeed, that has been a major key limitation, though. At least we started doing something. We're piloting a suicide surveillance system, which looks at retrospective reviews and active data collection in Lusaka. We started in the capital city. The goal is not just to gather evidence, but it's to develop a scalable model that can inform national funding and planning, right? We're thinking systems. And without accurate data, or policy remains disconnected from reality. So the first step that we've taken is to create a surveillance system. We're currently piloting it, and we are hopeful that we'll get good results out of that, and there'll be a lot of lessons learned to improve that area. And hopefully after that, we'll be able to scale it out to other cities, towns other than Lusaka.
Yeah, that sounds extremely encouraging. You were speaking earlier about, and you gave an example of how the work has progressed, but I wondered whether you'd care to jump in a bit more deeply and just describe how the research component has been integrated into the program overall.
Yes, this is not an easy thing, because we really wanted from the beginning to do very needed research, because we need evidence, but also extremely aligned to the needs of the country and the setting. So that makes that challenge our capacity of doing research, in the sense that you need to be very creative on how to measure without interrupting the implementation of these so needed interventions. So, and also to add a little bit more complexity, we really wanted to embed this capacity building approach into every aspect of the project. So we created a mentoring program where some of the health professionals that are part of the project are working with. So they are getting their research training through us as well, and getting a lot of expertise on suicide research. And every time you do mentoring, the pace of the research gets a little bit slower. At the same time, I believe the quality gets much bigger, but it's something that you need to balance. So I have, said all that to say we haven't published yet, but we have 3 papers that are about to be submitted, and just explaining the things that we have measured. The first is that we are collaborating with a biostatistician team to estimate and model the underreporting rate of suicide attempts, because we believe this is a key issue, not only in Lusaka, but in many other African settings. So we want to create a model that can be used for many other governments, public health officials, and researchers to estimate, to predict the level of underreporting, and to predict at the end, ultimately, the clear or a more approximate rate of suicide attempts. And we are using the data of this surveillance system to estimate the numbers that from reality to what was reported at the beginning. So that is one thing we will be able to learn and bring to the research field coming from this project. The second is the evaluation of the training program. We developed a training program that is also specific for a low-income setting. There are very few programs currently in the African continent, specifically for suicide prevention and suicide care management. So we developed this program and we evaluated the learning, the attitudes towards suicide, the capacity on identifying suicide ideation, the capacity to do an accurate risk assessment and care provision to people with suicide thoughts and suicide attempts. So we are measuring their improvement in these capacities, and we will publish on the effectiveness of this intervention that we did and training health professionals. And last, we are also about to send a paper establishing what are the perceptions of suicide among health providers and youth who have a lived experience. And this, we think it's key information. It's information that it's very hard to get, and to understand what are the main factors associated with suicidal thoughts, how stigma is involved into help-seeking behaviors for suicide. And we really want to develop this model of help-seeking behavior for suicide in Zambia that we hope can help other regions to understand and target interventions.
It's an incredible amount of data and research that you're producing, and excited to hear it and to see it when it's published. And Francisca, I know earlier you mentioned, data guides policy, and I think that's just an incredibly simple, fantastic, straightforward way to say the importance of data. And I'm curious, has the government formalized its support through policy to date?
Yes, we are supporting the suicide surveillance and suicide service because, as I mentioned earlier, this guides the data guides policy. The lack of data is what, for the longest time, as much as we are doing various interventions, we're not able to measure what the impact of the various things or interventions that we're doing. But now we're going about it in a strategic way and with strategic interventions. And the hope is that we'll be able to monitor this better. Through the research arm, Irene and the team also working on a monitoring and evaluation aspect and arm. So it speaks again to the quality of data that we'll receive and the sustainability as well of this project. So we don't want it to just end as research. No, this is something that we've needed for the longest time. So lucky for us, through Irene and the Swiss Tropical Public Health Institute, we were able to collaborate to achieve this. So this is something that policy was already guiding on, and then a platform presented itself for us to collaborate and do this work. And our hope, as Irene mentioned, there has been little work done in this area in Africa. So our hope is that Zambia can be one of the leading countries on the continent to lead with such adapted interventions. And we could share with others within the region on the success that we'll make, and hopefully even achieve global recognition and endorsement for the work that we're doing, and possibly it could be applied in other low and middle income countries in other regions of the world outside Southern Africa or Africa. Yeah, so that's our hope.
Well, that's a wonderful aspiration, and it sounds to me as if you and Irene are well on the way to achieving much of that. And what's so amazing and inspiring for Christy and myself is that you've done all of this with very limited funding. It would be very helpful, I think, and maybe we could invite both of you to comment here. It'd be very helpful if you could talk through the funding history of the program, and perhaps from your mutual perspective, what needs to change in the funding environment to sustain efforts like this.
This is a very important aspect, because without funding, nothing can happen. And you don't, as you were saying, Chris, you don't need a lot of funding. You need funding to start, to create the energy and the momentum, so people who are motivated in the field can start working on it, and to also pool the existing resources. So because this project has been funded by a very small family foundation from the beginning, and it has been very limited funding, we have had to pool these existing resources, which has been extremely positive. And I think it has brought amazing positive outcomes. Of course, because it's limited, we haven't done as much as we could. Of course, I could list you all the things that we would like to do in the future and where we would go from what we've done so far. But this limited funding allowed us to really go and pool the resources that were out there. For example, asking the clinicians for their time and support, and finding that they were so passionate about their work that they are already doing as public health clinicians. They are working at the hospitals. They are nurses attending cases every single day. They are paid through the Ministry of Health from the government. They are willing to meet with our team once a month at 6:30 p.m. to discuss how the implementation is going, how to better adapt the materials, where do we need to fix the new posters that they will be fixed in each of the emergency rooms. They are meeting at 6:30, at 7 p.m. They are staying with me to talk during the weekend. And these, we don't pay with money. And this is their expertise they are offering and sharing with us. Still, we are using the money because we have a team that needs to be in the ground, that needs to move around. We need all the materials to be produced in a good quality, so they are sustained and they are in the field. So all these cost monies, and the money that we had only allowed us to do it in Lusaka as a pilot case or as a pilot study. And our ambition is to actually move it across and scale it across the country, as you can imagine. So I think it has been key to work literally with the people who are already working in this, and they are already feeling that this is needed. So that's why it's so important to embed it within the existing resources, within the Ministry of Health and the people working there.
Thank you very much. Francisca, would you like to comment?
Yes, indeed. I think Irene has explained well, I think, where we are when it comes to this implementation. As I mentioned, the research was a great collaborative platform to facilitate something that we've been working on for some time, but maybe we're not achieving the level of success that we're hoping to receive. But with the research arm, which came with funding to complement the efforts that the ministry was doing, we were able to achieve more. As anyone who is in health management will realize or know, is that health is costly. And there are various pressing needs that are requesting of the same funding basket available. So even as much as suicide is important, it's a priority, we have many other health-related presentations that are equally urgent, with various emerging emergencies in the health sector that we've experienced in the recent past. So it calls for innovative ways to draw resources to facilitate certain works. So key for us as a ministry, and I think what also made the project very good, and I feel that will be sustainable, though it will take a lot of effort, is that we were using Ministry of Health staff. The training, capacity building was being made in the Ministry of Health staff. And in that way, that human resource is funded through the Ministry of Health. But of course, we acknowledge that there was need for extra human resource to coordinate this work. And it's those nuances, extra administrative costs to run, to ensure that the implementation is successful, to monitor that above all the day-to-day activities in the health facilities. And we would like to encourage, I think, many researchers, whether people who are purely in the research world or academicians, to see how can we collaborate to apply for grants in relation to suicide, to help scale up this project and to improve on the other aspects that are yet to be developed or implemented on the project. It's costly and to take a lot of investment to achieve what we're trying to achieve. And a lot of focus was on the health sector. But when we speak of suicide, it's not just the health sector. It's community. It's the other line ministries. It's the various point of entry of these suicide presentations, and being able to bring all those together, in addition to the various responsibilities that the Ministry of Health and other line ministries already have. So when we see these opportunities through research and other alternative grants, which could still be through research or other partners, it really helps to facilitate this work. So I'm hoping Dr. Irene will continue on this journey to get more grants, more funding, to see how we expand this program together. Of course, with our support as usual.
Amazing. Thank you. Thank you both so much. And what you've shared, and Francisca, what you've succinctly wrapped up as well, is a clear story of determined, evidence-backed, government-led and driven work to build a system that lasts and that is impactful and supportive, and clearly outlining the importance of thinking horizontally and collaboratively about things like funding and about resourcing. It takes a massive effort to implement and to do something like you're doing at a big national scale. And I think the story that you both shared today, it's a real reminder that real change doesn't come from quick fixes or imported solutions, but from folks who have a commitment around leadership and context-driven design and an interest in deep partnership and collaboration. And there's a clear thread around the importance of bringing together kind of global and local resources in order to make actual change happen. So the approach you outlined today is not just pioneering, it's practical, scalable, deeply rooted in needs and local context. And we're really grateful to have had the chance to learn from it. So really appreciate that. Chris, are there any reflections you want to share as we wrap up?
Sure, just a couple, but I mean, I absolutely endorse what you just summarized, Christy. It's a fantastic project, and we're so lucky to be able to meet with Francesca and Irene and to hear about it firsthand. And one of the things that I really like about the project is that it starts with first principles. It starts with, okay, here's a policy. This is the government. This is the ministry. We've got our policy. That's fine. And okay, this is not just about the Ministry of Health. It's also about other line ministries. It's about the way in which these ministries have to work together. Why? Because it's not just a medical matter. It's a social matter. It's a community matter. And it particularly affects young people. And so then there's the ministry, which is related to young people in other ways. And so it goes on. So I think that has been really interesting. So first practice in that sense, first base. Then the research itself. And what's so interesting there is that Ministry of Health staff have committed themselves. So in a way, whatever Dr. Bwalya and Irene Falgas-Bague produce at the end of the day, they will also feel, the staff themselves, that this is their policy and their work. And I think that is so important. And therefore, that leads to practice at a practical level, yes, but also the potential for it to be able to go wider and wider across Zambia. And I absolutely aspire to the same wish that Francisca had earlier in the discussion, which is that this becomes a beacon of hope for people right across Southern and then Africa all over, and then, of course, the rest of the world. And I was thinking, by the way, that because you were referring mostly to low-income countries, low or middle-income countries. But, you know, there are many low-income spots in high-income countries where actually this approach is just as valid and just as important. And I think that is something that we should also give consideration to when you think about your publications and your materials and so on and so forth, you know? So it just remains really for us to give you a very, very warm thank you from my part as well. Thank you so much for being with us.
Thank you. It's been a privilege.
Thank you so much, Chris and Christy. Thank you.
All the best.